discussion. You're sitting very unbalanced. Here, you two from this side. Why so?
We're
There were
very
no more
left.
chairs in there.
We're very left. We're left wing.
We'll just need a little bit to face this one. So, we are moving on to the risk factors and the modifying factors and all these conditions. So we will discuss now about smoking and periodontitis. If I'm standing here, I'm blocking your way from there. Maybe I have to push a bit here. Good. So, all these cancers you talked before, not necessarily related to smoking, but like the amyloblastoma I heard, and what else was in the discussion. But there is actually proof that it is very highly correlated with lung cancer. Almost 90% of the lung cancers we diagnose have to do with smoking. And it is also estimated that the millions of people every year where the death is closely related to smoking is only increasing. The 4.8 million was in 2000. Today, this number is by far higher, unfortunately. And also, if you take it in terms of quality of life and life expectancy, smoking is one of the major factors that can make life much shorter. Smokers have, on average, 13 years less, and if you are a smoker, 14 years less. Now, why is that? It's not because it affects female smokers more, it's because females live longer anyway, so the average is expected to be higher.
Wait, what?
Compounding factor again. So, smoking women and smoking men probably have the same impact. Let me see if this is better or this is the same. I think this microphone not so strong. No, it wasn't always like that. As you see here, this gentleman is the leader of the national football team of Germany, and he's celebrating the World Cup in 1952 by raising his cigarette up in the sky. So at that time, cigarette smoking was not really correlated with any bad or negative implication for health. Not only that time, actually the first suggestions about smoking being connected to disease or cancer, they come very sporadically. Some of them in 1940s and 70s, which is associated with some form of necrotizing gingivitis. And only the 60s, there is some radiographic evidence where people associate for the first time smoking with more radiographic bone loss. Then, moving on, in the 70s, there is the first time that plaque and cigarette smoking is associated. Still, for the greatest number of years in the modern times, smoking was not necessarily associated with harm, or it was quickly disregarded. Like this advertisement, like don't worry, chances of you dying hit by a bus or hit by a cigarette are not very different, so just go on, have a cigarette. And you could see some interesting advertisement, even using doctors. So more doctors smoke Camels than any other cigarette. Exciting marketing, you wouldn't be able to see this anymore today, but it was very common in the 50s and even in the 60s. Now, if I show you these four conditions, there are 4 patients of periodontitis. All 4 of them have periodontitis. Would you be able to tell me who is the smoker?
The top left?
Well, we are all tempted to make a guess because we always connect smoking to a bad outcome. But the truth is that you cannot say by the clinical manifestation who is the smoker and who is not. You might say by the staining, for example, in some patients, but that might not really be the case. The truth is that the doses of smoking is very important, how long they have been smoking, how much they're smoking, and what kind of oral hygiene they are practicing. So smoking not necessarily will be associated with the worst conditions, but very often people who have also bad conditions, they also smoke on top of that. Now, what we know from association studies. We know that those who have smoking, they have more periodontal disease. They have more severe periodontal disease as well. So smokers with periodontitis have more attachment loss, deeper pockets, and more bone destruction as a result of periodontitis. We also know that they lose more bone, and they lose the bone faster than the non-smokers. We know that they have deeper pockets and more teeth with deep pockets as opposed to non-smokers, and more sides affected by periodontitis, more sides with deep attachment loss. Now, there is also some other parameters such as the furcation involvement. Furcation involvement, as we will see later, is when the bone loss in the area of the molars comes below the furcation of the roots. And then it opens up a small cave right under the tooth. And this can be a prognostic factor, as we will discuss later. Smokers lose more teeth, and there is an interesting prospective study which took place in Sweden some years ago. And this study was conducted for 10 years consecutively, so a prospective study. What is interesting is that it was a population of Swedish musicians. And now, why musicians? Because in Sweden at that time, these people were playing music in different clubs or bars, and they were staying long hours, working in smoky environment, and also very often smoking themselves. So they selected the smokers among the group and the non-smokers, and they took some interesting measurements. So you see here 3 lines. The blue line is the smoker, the green line is a former smoker, and the red line is a non-smoker. And they measure how many pockets of 4 millimeter or more these people had prospectively. And you can see that those who were smoking, they really have a significant increase over 10 years. Those who stopped smoking, they are very similar to those who never smoked. It's the same progression, but they start a little bit higher, so they have more pockets and they maintain the same number. Now, interestingly, if I ask you, is this study able to prove that smoking causes periodontal disease?
No.
No, why not?
It just says that smoking is related to pockets, but
it's also prospective, so it shows that smoking prospectively year after year increases the number of pockets. So why not showing that it is actually causing pockets?
it could be a modifying factor since it's not before they smoke.
But what else, any other parameter? It could be modifying, but why it is modifying and not the risk factor true? Yes, we don't have a biological mechanism, we only have epidemiology. But there is one interesting parameter. Look at the baseline. Look how everyone starts. So at day 0, when the study starts, the non-smokers have very little, but the smokers already have pockets, which means that they already had periodontitis at the beginning of the study. They didn't get the disease during the study. So if the smokers and the non-smokers would start from the same point, then you could say that the smokers actually developed the disease during the study. But here you can see that the smokers already had the disease when the study started. So the study cannot prove that the disease was caused by the smoking. It can prove, however, that those who were smoking, they lost significantly more during the same amount of time. So smoking is a modifying factor which deteriorates the conditions. And from the same study, you can see also how the radiographic bone height changes through the years. So how the bone looks like throughout these years. You can see that there is a slight deterioration in the healthy people. It's exactly the same rate on the former smokers, but the former smokers already had lost some bone. So they start from a different line. And when it comes to smokers, they start really low, but they go much faster, even lower. So all in all, smoking would be modifying the response and making periodontitis more destructive, faster progressing, and more difficult to treat. Now, there are some other influences that smoking can have, and there has been studies showing that smoking can increase the calculus, can make patients to have more staining on the teeth and more calculus as well, and this can feed into the vicious circle of perimplantitis. So those who are smoking can have more calculus, the calculus leads to more plaque leads to more periodontitis, and then the vicious circle continues on. So multiple mechanisms. So we can assume and resume the conclusion that smoking is a modifying factor that can increase significantly the risks associated with periodontitis. By how much? And here is the odds ratio again. This odds ratio depends on the study. And some studies have found a low odds ratio, as low as 1.3. Some studies a higher one, around 3 to 5. And some studies as high as 8. But nevertheless, if you look overall the studies, it would be somewhere between 2 and 3 in the majority of cases. Now, to give you an idea, we said before that smoking and lung cancer has an odds ratio of 17. So smoking relation to cause lung cancer is much more clear. Smoking relation to periodontitis is probably much milder to the level of a modifying factor. You will see on the packages of cigarettes warning signs saying smoking causes periodontitis, for example. This would be not a scientific message, but mainly a general health trying to prevent people from smoking. But if you talk about scientific evidence, the evidence is on the modifying factor level. Now, what could be the effects of smoking on your treatment? So when you start treating periodontitis, will smokers have the same outcomes as the non-smokers? And here we also have a conclusive evidence. If people continue smoking, then healing will be less than the non-smoker in almost any type of intervention. So it makes sense, before you start your treatment, to try to help the patient quit smoking. This is just a compilation of different studies where you can see the effectiveness of the treatment if we have a smoker and if we have a non-smoker. And this is pocket reduction. So a pocket that is 4 millimeters, how much less can we make it with the treatment? Can we make it 1 millimeter shorter, 2 millimeters shorter? And you see always the non-smoker has better outcomes than the smoker, and also the same with attachment gain. Not that the smoker doesn't benefit from treatment. The smoker also will benefit from our treatment, but not as much as the non-smoker. So you cannot refuse treating a smoker on the basis that he doesn't want to quit smoking. It would be not an ethical approach, at least in periodontitis, but you have to warn your patient and prepare him and help him understand that if he doesn't want to reduce or quit smoking, the treatment will be more difficult, more compromised outcomes, and longer. And of course, it's his decision. At the end of the day, this is one of the greatest mistakes we do. We try to scare people rather than to help them take responsibility. There is some discussion about this smoking and ethical limitations of the treatment, but not so much in our field. It will be much more in other, for example, organ transplant or heart surgery. In UK, in national health care system and insurance systems, there has been a lot of debates of people who want to refuse heart surgery or transplantations to patients who do not want to quit smoking. And this is now an ethical discussion. Is this something that you can do? People will say you cannot refuse someone a life-saving intervention even if he chooses to smoke. Others will say yes, but when we have limited resources and you have to wait for a year to get the surgery, why should I deprive this surgery from someone who is willing to quit smoking and do this for someone who continues to smoke, and the other one will have to wait even longer. So there is always a lot of discussions in this. Luckily, we won't have to make any of these choices in our case. Now, this leads to the discussion about smoking cessation, about quitting smoking. And there is a lot of evidence which shows that people who quit smoking, they actually can have a very fast recovery to the non-smoker level risk within a few years. So if you can actually stop smoking, then you can show that the improvement of the results of your treatment will be almost the same as to those of the never smoking people after a few years of cessation. Usually you consider someone to be a former smoker when there is at least 1 year of not smoking. And then you can start really decreasing the risk levels as well. Now, question is, of course, smoking cessation. Is it something that we do? Is it something that we have a role? And is it something that we have to help our patients to do? And that's, again, a matter of many factors. Helping people to quit smoking will be a very, very important service you do for your practice and their care as well. So your treatment is going to be much more efficient if the patient doesn't smoke. How do you do this, however? What is your responsibility as a dentist to smoking cessation? What is your role into that? And here I think we make often a lot of mistakes. People would smoke for very many different reasons. And there will be many different interventions on trying to help them quit smoking. From a very, very small intervention, which we would call this short intervention, maybe to very big behavioral treatments, sometimes including medication. Now, as professionals of healthcare, we do have the responsibility to make patients aware and to make patients understand the implications and the responsibility they take. The mistake we do very often is that we take a judgmental approach. We tell them, smoking is bad for you. It's like, thank you very much, everybody knows this. So trying to decriminalize the action and trying to help the patient understand. And maybe the first interesting question, which is not judgmental and you can always ask to start this discussion, is, have you ever tried to quit smoking? And by asking them, have you ever tried to quit smoking, you can initiate this discussion, and then you can pose the final question, which is, do you want to quit smoking? Do you want to reduce smoking? And if the patient expresses his will, which most of them will do, then you can pick it up from there, and you can help them initiate this discussion, and maybe if you're not interested to continue this, you can refer them to a specialist, a smoking cessation center that can help them interfere and continue this treatment down the road much more efficiently. Now, people will smoke for many, many different reasons and with many different motivations and background, and depending on their motivation, there might be different strategies to help them quit smoking. Many people would be what we call opportunity smokers or social smokers. They would not smoke regularly on their own, but they will be eager to smoke when they have a drink with friends in the evening, especially if other people also smoke, or when there will be situations and occasions that help them feel that they want to smoke. And there you actually have a totally different trigger. There will be those who are what we call benefit smokers, and these are people who enjoy smoking, but they are not the typical chain smoking people. So someone who after his dinner will have a glass of whiskey and have a cigarette or two, that might be something that he really enjoys to do, but he wouldn't smoke regularly outside of all these setups. And this is also a very different type of motivation into smoking. People who smoke when they get stressed, and this is probably the most dangerous because this is only a self-feeding circle, then you feel that you can't relax without smoking, and eventually people end up smoking quite significantly and quite more. and people who are habitual smokers, who will smoke a lot of cigarettes even without thinking about it, just because they have nothing else to do, waiting for the bus, take a cigarette and smoke. Getting off the bus and walking in the street, take another cigarette and smoke, and that's habitual is also quite a difficult circle to break. And of course, there are people who are addicted who start to feel really uncomfortable and anxious and depressed if they cannot find cigarettes. You tell them you have to fly for 9 hours, they will never dare because they cannot stay for 9 hours without cigarette smoking. So these are probably the people who need even more intensive behavioral intervention. Now, if you look which different methods help people to quit smoking, and that is of course with 1 year success. You see, if you do nothing just by themselves, patients who declare a wish to stop smoking and they actually stop smoking is only 1 to 2%. Very, very little benefit. If you ask them, do you want to quit smoking? He says yes. And you say, shall we quit smoking now? He says yes. Chances that 1 year later he won't be smoking is 1 to 2%. Now, the short intervention is a little bit a behavioral approach where we start a dialogue with the patient, help them understand that they want to stop smoking, and then try to support them emotionally with maybe some motivation from our side in the treatment. Also low, 5%. Now, 10% if you combine it with nicotine replacement therapy. This is patches or chewing gum that helps them get some nicotine dose. And we can have now professional treatments, which is intensive consultation with a professional smoking cessation therapist. Now, these persons usually are hygienists or psychologists or behavioral therapists. I think that the dentist will hardly ever have time to commit to this type of treatment. So even if you enjoy psychology, you're not really getting paid for this part. So you will have to use your time probably in more dental approaches than that. And then when we have intensive consultation with nicotine replacement therapy, then you get high as 30–40%. And the most effective way to quit smoking is really when there is no alternative. Your doctor tells you that now you have to stop because you got a heart attack, because you had a condition, and there is no other way. If you don't stop now, you are going to face very serious imminent consequences. But unfortunately, we don't want to wait that much. So we want to activate people early on and try to push them to finish this journey quite early. Have you been having any lessons about behavioral change, psychology or so on?
We had one class that is similar to that, 1 hour about talking what not to say and what to say, but I don't think that counts.
It's very elementary, and of course when you start to deal with patients you will see. But much of your treatment success depends on how you can inspire people to change their style, their lifestyle, and to adopt habits. Oral hygiene is the same. Unless you can motivate them to really use oral hygiene effectively, you will never be successful in perio. So engineering the psychological side is really a big part of our work, and we are the healthcare professional who sees the patient most regularly than any other healthcare professional. They might not see their doctor so often, especially specialist doctors, but for the dentist, they will come to you at least once a year. So you do have really a very good rapport with the patient. The problem is we don't have the time to do these behavioral interventions. We have half an hour slots per patient where you have to do a filling, you have to do an extraction. You can't really fit a lot of time of behavioral interventions, and you cannot be paid for that. You cannot charge your patient for smoking cessation. While a professional will devote an hour and will be paid for that. So don't be shy. If you think that the patient is smoking a lot, always try to collaborate with a smoking cessational specialist. Just refer them and get them to get some help. Now, how does it work? Why smoking really makes periodontitis so much worse and modifies the immune response? And here there is no specific, again, single major mechanism that is identified. Apparently, cigarette smoking has very wide number of toxic substances in very different doses. Nicotine is only one of them, but there is so much more in cigarette smoking. It's almost like thousands of substances that have been identified to be toxic. So it's very difficult to know which combination or which exactly mechanism is what causes the trouble. There could be systemic effects like nicotine and all the inhaling substances. There could be also local effects because of the heat and because of the direct contact of the tobacco products and the paper burn products with the tissue. You see, also smoking can have different manifestations. Those who smoke cigarettes have a totally different pattern of pathology than those who smoke cigars, for example. Do you know the difference of cigarette and cigar? That's a good start, yes. Cigars are bigger, cigarettes are small. Yes? Cigarettes are very expensive. Cigars are much more expensive. So it'll be more like a rich man habit. Cigarettes, on the other hand, are much cheaper, but will be much more the habitual. You will hardly find addicted to cigar smoking people. The addiction will be more on the cigarette. Still, the big difference is that cigars are not tied in paper. They're not wrapped in paper. It's pure tobacco leaves wrapped in itself. And then the cigar smokers do not inhale the smoke. They keep it in the mouth and then they exhale, so it doesn't go down to the lungs. So cigar smokers will smoke maybe few cigars, one a day, one every 2 days or so, 3 maybe maximum. While cigarette smokers will smoke a lot, and cigar smokers will not inhale, so the lung cancer is not so highly correlated, but they will keep the smoke in the mouth. So for oral pathologies, like oral cancer, or leukoplakia, or changes on the mucosa, cigars are actually much higher correlated than cigarettes, depending of course on the consumption. Nevertheless, both would be harmful in any way you look at it. Now, this, yes?
Sorry. Which one is leaf in paper? Which one is leaf? Cigarettes?
Cigarettes are tobacco chopped in small pieces and wrapped in paper. So when you are smoking a cigarette, you're not only smoking the part of the tobacco leaf that is getting burned, you're also smoking the paper. And the paper in itself is actually harmful as well. For example, tar. The tar is not coming from the tobacco, it comes from the paper that is wrapped around the tobacco. Also, the tobacco leaves on the cigars are somehow, in a way, you can say that they're organically manufactured. There is a more traditional way of creating cigars, which is drying the tobacco leaf and wrapping it together. The cigarettes are drying tobacco leaves, then chopping them down into small pieces and blending them with other substances as well. So there is a lot of chemical ingredients in cigarettes that might not be there in cigars. So in a way, cigar is a bit more organic. Cigarette has much more toxic substances in terms of this composition. Both of them not particularly good to recommend anyway. Now, we have a study which tried to assess how gingivitis or inflammation starts in smokers and non-smokers. And this was exactly the same experiment as Harald Lowe did, the experimental gingivitis, but this time he had smokers and non-smokers and tried to go through the same process of 3 weeks abstinence from oral hygiene and then brushing again. And what can we see from this experiment? On the gray, the light gray one is the smokers, the non-smokers, and the gray one is the non-smokers. And you can see here that this one is the plaque index, this is the bleeding index, and this is the number of sites with more than 2 gingival index. And the pattern looks very similar. From day 0 to day 7, 14, and 21, we have a steady rise of plaque, and we have a steady rise of bleeding. So the conclusion from this study was that regardless to smoking or non-smoking, if you don't brush the teeth and accumulate plaque, gingivitis will be initiated to all of them regardless. And also, when they looked at the bacteria, they didn't see any significant differences in the bacterial composition between smokers and non-smokers. So as much as it comes to the initiation of inflammation, to gingivitis, both smokers and non-smokers react to plaque in a similar way. And the inflammation grows in a very similar way without any differences in the periodontal microbiome and the bacteria counts. With that, then one has to conclude that smoking doesn't necessarily change the initiation of the inflammation. It is still the bacteria. But when bacterial plaque starts inflammation in smokers, on the long term, the progression is very much different. Thus, we can also put smoking into the list of modifying factors together with diabetes. Now, when it comes to biological plausibility, loads of mechanisms and quite a lot of ways where harmful products can actually inhibit the conditions that we need. So not only make periodontal disease worse, faster progressing, more destructive, but also to limit our ability to treat. So the response, the healing response in smokers also is significantly compromised. Now, there is one school of thought which says, okay, you have been smoking for 20 years, and I am going now to treat your periodontitis. Would you be willing to stop smoking for 3 months, as long as the treatment lasts, and then start smoking again? What would you say about this approach?
Sounds good.
It's better than nothing, for sure, but would this solve the problem, you think?
Because if the patient goes back to smoke, if they manage to stop smoking for 3 months, then they would go back anyways.
Yes, maybe they will, maybe they won't, but yes, most likely people who only stop for this particular reason and they know from the beginning that they will be allowed to start again, they're just looking forward to the moment, and then 3 months and 1 day they order a nice bottle of whiskey and 2 packets of cigarettes and go again. Yes, now there is 2 aspects of smoking. There is a local effect, as we said, and there is a systemic effect. The systemic effect takes years to accumulate and might take longer period to also drop down. So if you stop smoking today, you cannot expect that tomorrow or the day after or in 3 months your body will be the same as the one of a non-smoker. And this is why we say that the non-smoker, a former smoker, should be at least after 1 year of cessation. On the other hand, there is also a local effect which is immediate. So if you have a fresh treatment in your mouth with a fresh wound from scaling and you keep smoking, you definitely make conditions locally very worse as well. So yes, if you can quit smoking for 3 months, you will certainly do something to improve the outcome of your treatment, but you will not really have as improvement as a former smoker or non-smoker. So ideally, we would like people to reduce smoking for the long term or quit smoking altogether. Some people might use this motivational trick to say, okay, stop while we have the treatment, but I think this is probably just better than nothing. I wouldn't start with this as a target. Probably better than nothing, but definitely not the ideal. So remember, very strong association between smoking and periodontal disease at the level of a modifying factor at this stage. At the same time, quitting smoking can have also a big impact for the periodontal disease, but for your treatment, both on the actual treatment outcome, but also on the long term. Now, if people continue smoking, then you expect less positive response to your treatment, the periodontal treatment, and you might need to keep them on closer maintenance, to recall them more frequently, and make them responsible to take care of themselves in a much more pedantic way, because you will expect more attachment loss and you will see compromised healing response in these patients. Having said that, as we said, it's still plaque that makes the initiation of the disease. Smoking doesn't seem to change this initial response. And what is the exact mechanism that smoking is causing all this remains not completely known. Although we have many, many small hypothetical and proven mechanisms that smoking is damaging the tissue. So, all in all, when it comes to smoking, remember, heavy smoking is something that we have to deal with because it will impact our treatment. We want to help people quit smoking, and that we can do with the first intervention that we are responsible, and then either continue the behavioral support or refer them to a cessation specialist. And if smoking persists, then they have to accept that they are getting into increased risks for the treatment of the teeth, but their general health. Now, moving on to some more factors that we might really have to consider is some other factors that have been associated with compromised outcomes and not really relating to the previous ones or systemic conditions. One of the most interesting one is stress. So there has been some studies which have tried to classify the personality of the patients according to their management of stress to group 1, who are the people who are positively and proactively able to deal with the stress in life, and group 2, those who are actually not able to cope with the right mechanisms, who appear to be more susceptible to stress on a chronic basis. And then they looked at the treatment outcomes and found much better treatment outcomes in those who seem to be coping with stress in a more positive way. Now, this is not just for periodontitis. Stress has been incriminated with pretty much any kind of inflammatory disease you can think of. And sometimes for a good reason, sometimes because stress seems to be the #1 thing that people can think as a cause when they cannot find any other cause to justify a diagnosis. So I wouldn't stay very much on this discussion, but I would like you to be aware that there is evidence that incriminates psychological well-being with periodontitis prevalence and periodontitis treatment as well. Can you think of ways where stress can actually link to all these kind of chronic inflammations? There can be direct ways and there can be indirect ways. And in direct ways is that stress is very well linked to the immune system. So conditions of constant pressure can influence your immune system directly by making your immune cells really less functioning, and that has been proven in scientific research. There is indirect ways where continuous stress can make you neglect your self-care. So patients under stress, they might sleep less, they might have less quality of sleep, they might neglect their nutrition, they might neglect their oral hygiene, and that can exacerbate the oral conditions and also periodontitis. So stress could be one of the reasons. And as a periodontist, you might see this not in the beginning, but usually at some irrelevant moments in the treatment or maintenance of patients. For example, a patient comes to you for a treatment, the treatment goes well, the patient stays in maintenance and comes to see you every year. And every year the condition is more or less stable, and then suddenly one year you see him and there is a really rapid deterioration. So this usually speaks of sudden changes, and stress is one of the most common ways of rapid deterioration. Now, when I say stress, I don't mean that suddenly this person started to worry about his life or his future, but I mean events that can be stressful. Can you think of stressful events in an adult life?
Being fired from a job.
For example, losing your job, very stressful. Divorce, and especially a bad divorce with legal fights, long-term, very stressful. Loss of a spouse, death in the family, loss of a child. I mean, these are events that can have very sudden stressful effects, and these will be the events that actually can also mirror themselves into oral conditions. and surprise you with a patient who has been for many years stable and suddenly deteriorates dramatically. So be aware for these particular factors. Stress would be also one of the modifying factors in many ways, and something that we also have to monitor. So every time you see your patients for the first time in this year, try to also make an update not only of the medical history, how much different medication they take, but also his social history, let us say. A few basic questions if everything is all right with life, work, family, and that might really give you some hints of what to expect and where to interfere. Any questions so far with regards to smoking or stress? Any of you smoking? Never smoked? No side? Never. I see a lot of people smoking electronic cigarettes lately, and that's what I don't think anyone knows the impact of this in oral health. Everyone says bad by default, especially when it comes to government agencies, they will always start, but it's very bad, but the evidence is very difficult to find and understand. So I would probably also not consider them safe before something is really shown, and usually it's not shown to be safe. Good, let's move on to the next topic then, which now is going to be a little bit about the predisposing factors. And predisposing factors is much more simple. Yes?
Why is prospective studies held more significance than retrospective studies, if there are history?
Yes, very good question. It has to do with the design moment. You see, if I'm doing a prospective study, I decide today what is important for me. And I say, I want to see x-rays, I want to talk to the patient, I want to ask them about this, I want to examine the gums, and I want to do this and that. And then you plan it, and you can do it today, and you can do it tomorrow as well. On the retrospective study, you decide what is important for you now, and you can do it now. But 5 years ago, you're not sure that you would get the same amount of information. Because now you say, I want to see the x-rays, but 5 years ago, did they have the x-rays? Were the x-rays taken exactly in the same way as you would like to take them now? Were the questions in the medical history asked in the same way as you want to ask them now? That is a bit rare. And because you haven't seen them in the in-between stage, sometimes you really cannot account for these things. So this is why retrospective is typically weaker, because we can't control what we have not decided back then. We can only control from now until in the future. Theoretically speaking, if you could find exactly the same quality of information today and 5 years ago, and you could have this observation period with the intervals, you could have the same impact. Usually it's not. But the retrospective is easier to do, it takes less effort, less cost, you just have to compile records, and that's why it's more common.
Retrospective?
Yes. Prospective, now you have to really invest much more resources, because you have to do new examinations in the future as you do today, so it usually takes more resources and effort.
But then it's more worth the time.
Yes, but it's more evidence coming from these studies. Any other questions? Good, let's move then to the last predisposing factors. And here I want to discuss two factors in particular. One is anatomic, and it's the furcation and the anatomic differences in the natural teeth that can make periodontitis progression faster or more difficult to treat. You all know what is a furcation. Furcation happens only when we have at least two roots. And two roots will be, which teeth will have two roots?
Molars.
Mandibular molars, or sometimes first premolar in the maxilla. And then maxillary molars will have three roots. Now, furcation is very different from tooth to tooth. And we would classify this typically in three different grades. If you can probe between the roots and your probe goes no more than 2 millimeters, then you will call this grade A. If your probe goes more than 2 millimeters, 3 millimeters or more, but it doesn't go through and through, this you will call grade 2. And if you can actually stick the probe from one side and it comes to the other, that means that there is absolutely no bone between the furcation area in the roots, then this will be grade 3. Now, what is the problem with the furcation and why furcation is a risk factor? And why does it matter if it's grade 1, grade 2, or grade 3? What is your thought on that? Well, furcation can be a very good hideout for bacteria and plaque. You see, this is now the margin of the soft tissue. From here to here, this is a pocket, and here there is a small cave. So if the biofilm has gone all the way down here, and then it populates the furcation, it will be very difficult for you, not only for the patient, but even for you, to clean the biofilm from in there, because your instruments will have to go really deep into a very small, narrow cave. So once the furcation is exposed, it suddenly becomes a difficult spot that can make things even worse for you and for your patient in the future. And the more loss distraction of the bone into the furcation, the bigger this cave, the more biofilm will accumulate in there. Now, looking at the epidemiology of the furcations, actually they start to show up quite early. If you look at what is the impact of loss of teeth, in the age group of 30 years old, the most likely teeth to be missing is actually first and second maxillary molar, and then also first and second mandibular molar. So the furcation teeth, they are the ones that also most likely to be missing. In the age group of 30, already by 15 to 20%. When you go to 50, you are having higher chance of people missing these teeth, almost like 1 in 2 might be missing one of these teeth. And when it goes to 60, it's actually more than half that will be missing one of these teeth. So furcation-related teeth are actually very often the first teeth to be extracted as a result of periodontitis or even caries. Now, looking at the furcation, there are a few numbers when it comes to the prevalence of the furcation, so I would like you to remember these numbers maybe a bit more vividly. So I would invite you to play a game. You might know this game with another title, not the periodontist one. Nevertheless, same game. I will get you a question and you will have to give me the answer out of 4 choices. So first question, how common is furcation in referred patients' upper molars? And I'll give you some options here. First one, 75 to 82, 15 to 32, 55 to 72, and 25 to 52%. Who says A? Nobody. B. That leaves only 2. C. Okay, the majority says C, or what about D? D, anyone? Okay, looks like you have by somehow missed this first one. It's okay, we have a second chance. Second question. How many referred patients in the age group 40 to 49 have a class 2 or a class 3 furcation? Now this one is simpler because we have older people and we're looking for just one class 2 or class 3. And again, A, 25, B, 55, C, 35, or, sorry, I jumped. I ruined the game here. It was me. You'd only have to make a choice. 55% of 40 to 49. Now this comes from a very specific study. This is why we have to say referred patient. What does it mean, referred patient?
They came for something else, but then they found something, and then they brought it.
They came for something, and this something was periodontal treatment. So as a general dentist, sometimes you might see a patient who has very advanced periodontitis, and then you refer this to a periodontist or to the university for further treatment, so this becomes referred patient. So these are usually patients with already advanced stage of disease, and this is why you will have really high frequency in these patients. So maybe that's not the average patients that are coming at the door. So these are some of the epidemiological factors. You can see in these tables this frequency of these conditions. It's mainly to give you an idea of how often you will encounter this problem, and also how often this problem will require intervention. And you can see the furcation or ability to close the furcation is also depending on the degree. Class 1 is probably the easiest one to treat and deal with. Class 3 is the most complicated and the most difficult. Yes?
What's class 1, 2, and 3?
Remember in the beginning we mentioned
A,
the
B, and
grade.
C?
1, 2, 3. It's, let me just go back to the slide. This one.
Oh.
So grade 1, 2, and 3. How much your probe can penetrate. So if there is enough bone between the roots, but you can only poke for a millimeter, that's class 1. If you can get in between the roots for about 2 millimeters, at least, this is class 2. And if you can go through and through, then it means there is no bone between the roots. This is class 3. So if your patient is class 1, you have a good chance to stop the periodontitis and close the defect. If it is class 2 or class 3, it is much more difficult. And it might take periodontal surgery, so you might have to refer this patient to a periodontist for surgical intervention. And this is a little bit the prognosis difference in the furcation defects. Let's look at some furcation defects to understand a bit more how things look like. What do we have here? How would you describe these roots? Sorry? Do you have a furcation here? Yes.
Yes.
But what else do you have?
Fused?
Fused. The roots are fused, and there is a wall on the palatal root which is binding them with the other roots. And what is this?
Plaque?
Not really. Could have been calculus, for example, but it's not. What does it look like? Does it look like a hard, like a deposit, or soft, or what do you think it is?
Is it something curl?
It's an enamel pearl, what we call. So in the region of the furcation, very often there is small anomalies. And this one is a small bump of enamel which is out of place. Instead of being together with the enamel, it has been apposited here on the cementum of the root. And this happens often in the furcation. And if this happens, it's very, very difficult for you to scale in here. So you see, while we extracted this tooth, this is the only area that was not properly cleaned. The rest of the tooth was actually clean, but not in here. Very difficult to access and clean there. Now, this is another furcation. What is the difference between the furcation left and the furcation right?
A bifurcation and a trifurcation?
This is actually the same, but yes, you cannot see that there is another root at the back side. The difference mainly is that here we have much more distance until the furcation. Here the furcation comes only 3 millimeters after the cement-enamel junction. Here it is another 3, so it's 6 millimeters. So technically speaking, if this patient and this patient gets periodontitis at the same time, it will take double the amount of years until you have furcation involvement in this patient. So sometimes furcation can be very early, sometimes it can come very late because of the anatomy of the roots. And sometimes you might have no furcation, you might have fusion of the roots or groove. Like you can see in this molar here, there is no real furcation, but there is a deep groove. And the groove is also very negative. It's almost worse sometimes to have a groove because it's very difficult to clean it and it goes rapidly in the apical direction if it gets biofilm. So some strategies to treat teeth with furcation. Most of them are surgical. You can do open flap debridement, or you can have these kind of preparations where you go with a tunnel under the furcation. Sometimes you can eliminate furcation by removing one of the roots, of course in cases where the tooth is root canal treated, or you can do some regeneration treatment, which is a surgery that tries to build back the bone and cover the furcation again. But that will be all things that you will learn next year. I don't think you have to worry about the furcation surgical interventions at this stage. I just want you to see a few of these approaches and how it looks clinically. So here we see furcation. This is exactly the same tooth. This is before we have cleaned and scaled with a lot of calculus, and this is after the cleaning. And of course, after cleaning, we have not corrected the defect, but now the patient can use interdental brush and clean in between the roots and hopefully prevent the inflammation from getting worse. Again, furcation full of calculus under surgery. And you see that these calculus have been left there after cleaning. So we tried to clean it before the surgery, but it's very difficult to remove when it's very deep inside. And that's why sometimes we need surgery to open up, see exactly where is the calculus, and then get it removed. Similar furcation that is closed there. And two different furcations. What grade do you think this one is? 1, 2, or 3 would you say?
2.
Probably. I'm not sure until I probe, but that looks more like 1 or 2, not a 3 one. While if you look at this one, what would you expect? Yeah, probably a 3 one. That looks like there is a really hole, a cavity under the roots and nothing in there. Good, let's move on with the next topic then, which now will be calculus. And calculus, or tartar as it sometimes is mentioned, is something that has been observed since ancient times and actually was criminalized as one of the main causes of disease. In reality, it is just mineralized deposits that accumulate on the teeth. So historically, moving calculus out of the teeth was a way of trying to treat any oral disease. And many treatments have been based on these scary instruments that were scraping away everything possible from teeth in the older ages. Today, I think we see calculus much differently than in the past. Sometimes you might have really horrible calculus conditions, like this extreme case of a person who had, he was mentally also compromised, he had significant mental problems, he has not been allowing anyone to touch his teeth, and then negligence and neglect of many years have led into this massive accumulation of calculus. You might be really surprised, however, that once this calculus is removed and is taken out of his teeth, then you can find underneath the teeth quite in relatively good condition. Now this is so much calculus you can still see it in the X-ray, but this is how it looks after all this bulk of calculus has been taken away, and this is how it looks when the teeth have been cleaned and had some time to heal. Not as bad as you originally think. So sometimes calculus in itself is not really doing the damage, but the damage of course is done by the plaque, which is hiding on top of the calculus and even below in sometimes. Now, in our cases, we will always find some accumulation of calculus, even in patients with good oral hygiene, starting from the lingual sides of the lower anterior teeth, and also on the first molars on the buccal sides. And it's a clear connection there why this happens. And it has to do, of course, with the salivary glands. As we said, this is mineralization, and the minerals comes mostly from saliva. So where saliva comes and flows in the mouth, minerals also come and get attached into the biofilm. So plaque can be, calculus can be scary from time to time, but it can also be spectacular how calculus can be removed and how can be prevented from accumulation. So where do we get most calculus? It depends. Where can we clean? So areas in the mouth that cannot be reached very well by oral hygiene. It depends on the location. So lower incisors and first molars in the upper might be the spots for first calculus accumulation. It depends, of course, how frequently the patient comes to the dentist, the diet of the patient, the age, and also genetic predisposition. It is also shown that different people build calculus with different rate. There might be people who make quickly, fast, a lot of calculus. People who, even without very good oral hygiene, might really take much longer. So the minerals in the saliva and specific composition. Now, we try to measure calculus in many different ways. So there is many different systems to index calculus, depending on how much surface of the tooth, for example, is occupied by calculus. I think the most common approach is not to use these complex ways of measuring calculus, but rather to look into the surface close to the gums at 3 points for every tooth and say yes or no, presence or absence. How is it developed is also quite well understood. It has to do with the biofilm. The biofilm, as we said, is a matrix of bacteria glued together in an extracellular matrix, a glue that holds them together. Now, if minerals from the saliva or from the food are caught into this matrix, then they start to cluster and they start to build and mineralize the matrix, and the matrix starts to become full of minerals and eventually build up like a strong hard substance like calculus. And this is just a microscopy photos where you can see the bacterial plaque with red and then small islands of minerals being built inside. Once these islands merge together and they become stronger, then the biofilm starts to become like the wall of China, built, concrete, and hard and solid, and then plaque forms again on top of the wall, and then the next layer becomes the next wall until it really gradually increases in size and it covers the whole teeth. So if you look at calculus in itself on the microscope or in the lab, you will not find any components that can have direct toxic effect on the tissue. It is not antigenic as such. It is only the bacteria that stay on top of the calculus that produce the antigenic substance. The calculus itself, it's 80% of organic components and 20% inorganic, different minerals and different substances and ions that can be collected from saliva flow. The organic components is usually proteins, carbohydrates, and content that you can find in the saliva and water. Now, why would this be really pathogenic? This has to do, of course, with the fact that it is a hard substance, it's a porous surface, and it can absorb and retain toxins. So when biofilm spreads on top of the calculus, then calculus starts to serve as a very good home for the bacteria, even better than before. And of course, this now can reinforce the mechanism of periodontitis. This is why we would put it in the predisposing factors. How can you prevent the formation of calculus? Again, prevent the formation of biofilm. As we said, one of the most important factors for calculus is to have the glue that holds the cells together and gets the ion. So if someone has good oral hygiene and removal of the biofilm, they will also have much slower rate of calculus. Oral hygiene is a main prevention, and then there has been some anti-plaque agents also produced, like mouth rinses, which can help prevent the accumulation of all these minerals into the wall of China. And these agents have been zinc, diphosphonate, pyrophosphate, and triclosan. That's the most common ones that you can find in either toothpaste or in mouthwash, and they can support patients who are forming calculus way too fast. It wouldn't be necessary for everyone, but for certain patients this might give some advantage. So pyrophosphate, which is the most common one, I think in commercial it has been with the Colgate, the PerioGuard. I don't know if he has ever been in Thailand, but this one is a mouth rinse and can reduce the formation of calculus between 20 to 40% depending on the situation and the patient. There has been quite a lot of studies to show these results, but I think in reality most of these substances will be directed towards specific patients. So you can't directly say to all your patients you should rinse with this substance unless you have some indication that this patient I did cleaning today, and after 3 months he came back for a review and there was new calculus everywhere. So that might be a patient who is building quite fast. Maybe they can be helped with this mouth rinse. Now there are two different types of calculus as well. There will be the supragingival, which is sitting on top of the gums, and usually this is what accumulates in the mandible on the lower incisors, and this can be quite easy to remove and not connected with periodontitis. But there will be also the subgingival plaque, and that might be much more harmful. So the supragingival could be white or yellowish. It usually accumulates in specific spots and can be removed rather quickly. The subgingival can be much smaller in extent and usually accumulates only under the gums and can be darker brown, smaller, and more difficult to remove because you have to get really a very good grip in order to scrape it away. It's not visible, it's smaller, and usually when you try to scrape it, you might end up just polishing it instead of completely removing it. Now, which one is more harmful? It's the subgingival one. So the one that makes the difference with the periodontitis is subgingival. How can you diagnose it? You cannot see it. You have to feel it with your probe. So when you put your probe through the roots and you touch the root, you have to feel and sense that there is subgingival calculus there. Not necessarily the easiest to remove, and this is why we need sometimes surgery. So if you have a deep pocket, a lot of calculus in the deep pocket, then sometimes you have to open the gums and look directly where it is and take it out. Even more difficult, these small islands of subgingival plaque. You see here we have scaled, but we have not been able to get this out. We always miss some small spots, and that's why surgery might be essential in order to help the tissue recover. Do you think you can see calculus in an X-ray?
Yes.
Yes. Every time or conditional?
Every time?
Yes, you can see it because as we said, it's mineralized. So it's minerals and it's actually as dense as the root cementum sometimes. So you could spot it on periapical X-rays, like this one here, where you really can see the layers of calculus on top of the root. However, you can only see it if it's mesial or distal. You cannot see it on the X-ray if it is buccal or lingual, because it's hidden by the root. So you will see the extensions to the sides, like this one here, but you will not see how much calculus we have on the buccal side. And that can help you also see the effect of your treatment. So if you can probe and there is no plaque, you can also maybe check the X-ray and see that you have really removed all the calculus from the sides. Any questions so far on calculus or on?
For the, sorry, it's
Yes.
from like last slide, from the rating of bifurcations. Is it 2 millimeters or 3 millimeters? That
The
changes
penetration.
between, yeah, that changes between grade 1 and grade 2.
Yes, let's go back to this original slide here. Well,
2 or
the,
3?
the definition is not really so much stuck on the millimeters. It's mainly also having to do with how much bone is left in there. So 3 millimeters is a rule of the thumb, because if you can be less than 3 millimeters inside, then you probably have little bone loss. If you can be 3 or more, then you probably have more than half. And if you can be through and through, then you know that there is nothing left. So the 3 millimeters is the rule of the thumb. Essentially, some others will say, oh, if you look at the distance, the mesio and the buccopalatal distance between the roots, and you say 1/3, 2/3, and 3/3, something like that. And because our periodontal probe has a grading of 3 millimeters very commonly, we just use the 3 millimeters as the rule of the thumb. Good. Any other questions so far? Good. Then let's have a small break here and we can continue with the last part of the predisposing and one more discussion right after.